Hi, anatomy students, and welcome to Unit 4 and Module 4, where we'll go through the cardiovascular system, your respiratory, your lymphatic system. Tonight, or in this lecture PowerPoint, I'm going to get through your cardiovascular system, as well as a cardiac output PowerPoint that's about 12 slides long. That's within this module as well, that you'll be encouraged to study that material as well. So the cardiovascular system, I hope you are learning a lot of the anatomy in this in lab, because there's a lot of anatomy associated with the heart and the blood vessels. So please spend some time learning that anatomy as a part of your lab portion for this course. But at the center of your cardiovascular system is your heart, and that is the pump that will propel blood to and from most of your body tissues via two basic types of blood vessels called arteries and veins. Arteries will always carry blood away from the heart, and veins carry blood back to the heart. The arteries and veins entering and leaving the heart are called the great vessels. And blood flow through the heart is always unidirectional, meaning it only goes in one direction. Blood never goes back the way it came in the heart, and if it does, that is a cause of problems. Because this unidirectional direction of blood is because of the four valves located within the heart. The heart is basically a two side-by-side pump system that work at the same rate and pump the same volume of blood. One pump on the right side directs blood to your lungs, where the blood will pick up oxygen, and one pump directs blood to most of the body tissues. That's on the left side of the heart. The heart generates blood pressure through alternate cycles of the heart's wall's contraction and relaxation. Blood pressure is the force of the blood pushing against the inside walls of blood vessels, and a minimum blood pressure is essential to circulate blood throughout the body. If blood pressure becomes too low, then the heart has to overwork or exert itself more to try to get that blood circulated throughout the body. And if blood pressure becomes too high, there's usually some sort of blockage in a vessel. So here's a look at the circulation circuits. We have two cardiovascular circulations. The pulmonary circulation includes the right side of the heart and the pulmonary arteries and veins. So this includes the blood going to the lungs, picking up oxygen and returning to that heart. The systemic circuit includes the pump on the left side of the heart and all the arteries and veins, which will convey blood and oxygen to most of the body tissues before coming back to the right side of the heart. So here's the basic pattern of blood flow: the right side of the heart to the lungs to pick up oxygen, back to the left side of the heart, and then all to your body's system and tissue cells. The position of the heart lies slightly left of the midline, deep to the sternum, in a compartment of your thorax known as the mediastinum. And you can see that compartment here. The apex of the heart is the pointed portion at the bottom. And you can see how the heart lies slightly to the left of the sternum in this picture. Characteristics of the pericardium, which is the tough sac that encloses the heart. The pericardium restricts the heart movement so that it moves only slightly within the thorax. And it's composed of two parts. The fibrous pericardium is the tough outer sac, and the serous pericardium is composed of the parietal and visceral layers. The visceral layer covers the epicardium, or kind of the surface of the heart itself, and the parietal layer will cover kind of the body cavity. Those two layers form a space in between, and that space is called the pericardial cavity. The heart wall structure is made up of three layers. From superficial to deep, we have the epicardium. This consists of that visceral layer of your serous pericardium. The myocardium is the cardiac muscle cells. It's the thickest. And then the endocardium is the internal surface of the heart chambers and external surface of your heart valves. The external heart anatomy, again, pause the slide here, but you should be learning or have learned or already learning the external and internal heart anatomy. So I won't spend a lot of time on it here, but you should be very familiar with the external heart anatomy as well as the internal heart anatomy. The auricles is an anterior-inferior border of the atria. That's a muscular extension. The atria and ventricles are separated by a groove called the coronary sulcus. And the anterior and posterior interventricular sulcus will be located between the right and left ventricles on the front and the back sides of the heart. Here are the heart internal anatomy, the chambers and valves. So the heart has 4 chambers. The chambers on the top are the atrium, and the chambers on the bottom are the ventricles. And the right side of the heart will be always on the right side of a person or a patient's body, not how you're looking at it. And the left side of the heart will be how it would lie in a patient or a person itself. The heart possesses 4 valves. The atrioventricular valves lie between the atria and the ventricle. So on the right side, you have the tricuspid valve, which is made up of 3 cusps. On the left side, you have the bicuspid or mitral valve, which is made of 2 cusps. And then you have the semilunar valves. The pulmonary semilunar valve lies at the opening to the pulmonary trunk, and the aortic semilunar valve lies at the opening to your aorta. So here's a great table that reviews all the heart valves, their location, their structure, and their function. So again, it's very important to learn those too. The right atrium receives venous blood from the heart, the muscles, and the systemic circulation. You have 3 veins that drain into the right atrium, the superior and inferior vena cava and the coronary sinus, which comes from the posterior aspect of the heart. Separating the right atrium from the right ventricle is the right atrioventricular valve, also known as the tricuspid valve. Deoxygenated venous blood will flow from the right atrium to the right ventricle through that right AV valve. And the right AV valve is forced closed when the right ventricle begins to contract, which will prevent any blood from going back into the right atrium. The right ventricle then will receive the deoxygenated venous blood from your right atrium. An interventricular septum or wall forms a thick separation wall between the right and left ventricles. And the inner wall of each ventricle displays these large irregular muscular ridges called trabeculae carneae. Typically, the right ventricle has 3 cone-shaped muscle projections called the papillary muscles, which will anchor the chordae tendonae, these connective tissue strings attached to the right atrioventricular valve cusps. The cusps are triangular flaps that hang down into the ventricle, and the chordae tendonae will prevent the cusps from flipping into the right atrium when the right ventricle contracts. The right ventricle, beyond the conus arteriosus, is the pulmonary semilunar valve, which marks the end of the ventricle and the beginning of the pulmonary trunk. So blood will flow through the pulmonary semilunar valve to travel through the pulmonary trunk and into the lungs. Oxygenated blood from your lungs will travel through the pulmonary veins to the left atrium, and the left atrium and ventricle will be separated by the left atrioventricular valve, also known as your bicuspid or mitral valve because it has 2 triangular cusps, and the left atrioventricular valve is forced shut when the left ventricle will contract. The left ventricle then pumps blood to the entire body except for the lungs, and therefore has to generate a great deal of force. At the superior end of the left ventricle is the other semilunar valve, the aortic semilunar valve, located right here where my cursor is, and that marks the end of the left ventricle and the beginning of the aorta. And if we look at the comparison of the right and left ventricular wall, the left ventricle is about 3 times thicker than the right because it needs to generate more force of contraction to pump the blood out of the aorta and into all the body system cells. Coronary circulation describes that even the myocardial cells within the heart need oxygen in order to function. So the right and left coronary arteries will travel within the coronary sulcus to provide blood supply to the heart, like oxygen and nutrients. The coronary arteries are the only branches given off by the ascending aorta, just superior to the aortic semilunar valve. The right coronary artery branches into these arteries shown here, the right marginal and the posterior interventricular artery. And the left coronary artery will branch into the anterior interventricular artery. We also call that the left anterior descending or LAD artery. And this will supply the anterior surface of both ventricles and most of your interventricular septum. The circumflex artery kind of goes around to the back and supplies the left atrium and left ventricle. Venous blood, so then the blood going to the heart needs to be drained. So venous return of blood from the heart wall occurs through three major coronary veins, the great and middle cardiac veins and small cardiac vein. And all of the above will eventually drain into the coronary sinus on the posterior side of the heart, which will drain directly into the right atrium. Here's a contraction of heart muscle. Cardiac muscle fibers will contract as a single unit because they are all connected with low resistance cell-to-cell junctions called gap junctions. These gap junctions comprise the intercalated discs shared by adjacent cardiac muscle fibers, and therefore an electrical impulse will be distributed immediately and spontaneously through the myocardium. I'd encourage you to download the PowerPoint and look at this great animation of the contraction of the heart muscle due to the electrical signaling. Organization and histology of cardiac muscle. You can see very well from a histological view from a light microscope these intercalated discs and how heart cardiac muscle has striations as well as branching to it. And you can see here the longitudinal view of cardiac muscle cell with its striations, the sarcomere, the sarcolemma, transverse tubule, sarcoplasmic reticulum. So this is just how the myocardial muscle cells are organized. The heart's conducting system. So the heart exhibits what we call autorhythmicity, which means it is capable of initiating its own heartbeat independent of any external nerves. And the pacemaker, or the specialized cardiac muscle cells that will initiate this electrical impulse or the heartbeat, is called the SA or sinoatrial node. So this is called your heart's pacemaker. The SA node is located on the posterior wall of the right atrium, adjacent to the opening of the superior vena cava. Impulses from your SA node will travel to the left atrium and the atrioventricular node located in the floor of your right atrium, shown here. The impulse then leaves your AV node and into the atrioventricular bundle, which will extend into the interventricular septum. Once in the septum, that bundle divides into right and left bundle branches before dividing again into Purkinje fibers that will innervate all of the cardiac muscle cells in the myocardium. The bundles pass the impulse to the Purkinje fibers. The Purkinje fibers spread the impulse superiorly from the apex of the heart to all of the ventricular myocardium cells. So here's a look at how a pacemaker, and this is another great animation. Basically, in order, when people get pacemakers installed, they install the pacemaker and then put the lead, the metal kind of string from the pacemaker through the heart to bypass the area of the heart that's having problem initiating or spreading the signal. And that's how pacemakers will work. And this is a great video. Again, download this PowerPoint to watch that. Innervation of the heart. So the heart, like most other organs, will be innervated by both your sympathetic and parasympathetic divisions of your autonomic nervous system. The anatomical components of both divisions make up the cardiac plexus, which is the group of nerves going to the heart. Autonomic innervation does not initiate a heartbeat, but it can increase or decrease the rate of the heartbeat. So sympathetic innervation will increase both heart rate and force of contraction, and parasympathetic innervation will decrease the heart rate. Sympathetic innervation will start with neurons located in your T1 to T5 segments of your spinal cord. This kind of takes you through how the pre- and post-ganglionic axons will enter the sympathetic trunk, synapse on ganglionic neurons, and then travel through the 3 cervical ganglia to the heart via your cardiac nerves. And it's just, again, important to remember that your sympathetic nervous system and input to the heart will increase the rate and force of heart contractions. And that's why we call your sympathetic nervous system the fight or flight response. The parasympathetic innervation will decrease heart rate. It will start with neurons in your medulla oblongata via your left and right vagus nerves. So that's cranial nerve number 10. And your parasympathetic innervation, again, decreases heart rate. Again, that's known as your rest and digest division. When we tie it all together, the cardiac cycle is the time from the start of one heartbeat to the initiation of the next. So it includes all the events within a single heartbeat. the contraction, relaxation, electrical events, filling of the chambers, and then ejection of blood. Contraction of a chamber is called the systole, and relaxation of a chamber is called the diastole. The cardiac cycle is the sequence of events in one heartbeat. It is the simultaneous contraction of two upper atria, followed by a fraction of a second later by the simultaneous contraction of the two ventricles. Phase 1, the systole, this is the term for contraction, and this will occur when the ventricles contract, closing your AV valves and opening the semilunar valves to pump blood into either the pulmonary trunk or the aorta. And then phase 2, the diastole, this is the term for relaxation, and this will occur when your ventricles relax, allowing any back pressure of the blood to close the semilunar valves and then open your AV valves again to fill them. So these are the 5 phases of the cardiac cycle, which you should be semi-familiar with. You'll study these a lot more when you get to physiology. So you can look at what happens during atrial systole. The atria will contract and blood will go into your ventricles. Early ventricular systole, the ventricles will begin to contract, but that increase in pressure closes the AV valves. That's the first sound you hear. And we call it the first heart sound when the doctor listens to your heart in a stethoscope. That's the closing of the AV valves. Then late ventricular systole, the atria relax and the ventricles will contract. That will eject the blood out of the heart. And then early and late ventricular diastole involves basically the closing up of all valves and then the opening of your AV valves again to fill up the ventricles. Blood flow through the heart. So this gives you a really good kind of description, review, if you're still kind of lost on how blood flows through the heart and then through the body. So I'd encourage you guys to take a minute, pause this lecture, and read through this great summary table of blood flow through the heart. Sounds of the heartbeat. The cardiac cycle creates heart sounds. They're the lub-dub, lub-dub, lub-dub sounds you hear in a stethoscope. The first sound is the loudest and the longest, and this is caused by the ventricular systole, which is the closing of your AV valves. And the second sound is caused by the closure of your semilunar valves. And you can go to this link to listen to a great rendition of these heart sounds. Blood vessels then. So the blood that circulates through the cardiovascular system is carried in your arteries, your veins, and your capillaries. Arteries always carry blood away from the heart, and most carry oxygenated blood, except for your pulmonary arteries, which carry deoxygenated blood to your lungs to pick up oxygen. Veins carry blood back to the heart, and most veins carry deoxygenated blood, except for your pulmonary veins, which carry oxygenated blood back from the lungs. Capillaries will contact tissue cells and serve cellular needs by offloading all of the nutrients and oxygen or hormones that your tissues need. Here's the structure of blood vessels. They're composed of 3 layers or tunics. The tunica intima is composed of simple squamous epithelium. The tunica media is the thickest layer in your arteries. This is made up of sheets of smooth muscle that can contract or relax, causing vasoconstriction or vasodilation. And the tunica externa is composed of connective tissue. The lumen is just the central blood-filled space of the vessel where blood will travel through. You can see here how veins have thinner tunics than arteries, and also veins have valves built in to close when blood gets up a certain point to try to help counter the effects of gravity to help get the blood back to your heart. These valves will close to help get the blood back to your heart quicker. And then they're connected by capillaries, which have the thinnest layer. And the capillaries will be where all of your gas exchange and nutrients and hormones will be offloaded or onloaded. Arteries are blood vessels that transport blood away from the heart. You have 3 types: elastic, muscular, and the arterioles. Except for your pulmonary arteries, all carry oxygen-rich blood. And the artery that carries oxygen-rich blood from the left ventricle is the aorta. It's the largest artery in the body. It travels away from the heart, and it will branch into smaller arteries so that all parts of the body are supplied. And the smallest arteries are called arterioles. Arteries carry blood from the heart to capillaries and the rest of the body. Their walls are generally thicker than most veins, And the smooth muscle cells and elastic fibers that make up their walls help give arteries a very tough and flexible structure. This enables them to withstand the high blood pressure of blood as it's pumped from the heart. And the force that that blood exerts on the walls of the arteries is known as the blood pressure. Blood pressure is measured using a blood pressure cuff, and many of you who are MAs or EMTs probably know how to take blood pressure. The cuff is inflated around a person's arm to stop the flow of the brachial artery. And then as the air pressure in the cuff is slowly released, it causes turbulent blood flow to go through that artery. So when you hear the first sound through the stethoscope, that's the systolic pressure, or the pressure of the blood when it leaves the ventricles. And the second sound, or the time of the pressure when you hear the last sound coming through the artery, that's known as the diastolic pressure. So normal systolic pressure is usually between 100 and 120 millimeters of mercury. And then air pressure will be continued to be released until the sound goes away. And when the sound goes away, that last pressure at which you hear the last sound, that's known as the diastolic pressure, or the pressure of the blood that's sufficient to keep arteries open constantly. And that's normally between 70 to 80. So your blood pressure is given to you as a fraction with a systolic number on the top and the diastolic number on the bottom. And 120 over 80 millimeters of mercury is considered normal, with anything above that hypertension or high blood pressure. Capillaries are when your arterioles will branch into networks of very small blood vessels. They're very thin walled, so only one cell can get through. The walls of the capillaries consist of only one layer of cells, making it easy for oxygen and nutrients to diffuse from the blood into the tissues. And this also allows your waste products to then be distributed to the venous system and carried away. The force of diffusion drives carbon dioxide and waste products from the tissue into the capillaries. Capillaries are extremely narrow, and blood cells will pass through them in a single file line. Veins includes the flow of blood, moves from capillaries into the veins back to the heart. They primarily carry deoxygenated blood, again, except for the veins that are coming to the heart from your lungs, those pulmonary veins, which will carry oxygenated blood. Vein walls are generally thinner, less elastic. They're more flexible and able to stretch out. This flexibility reduces resistance to flow of blood that it encounters on its way back to the heart. Large veins contain valves that maintain the one direction flow of blood, and the flow of blood in veins is also helped by the skeletal muscle pump, which will be muscle contractions in the arms and legs that help to force the blood back towards the heart. Here are the structure of arteries, veins, and capillaries. You can see how arteries have the thicker tunica media muscular layer, and they are able to kind of stay open by themselves, whereas veins have thinner tunics to them and can collapse much more easily. Elastic arteries are the largest. This includes the aorta, the major branches. They're called the conducting arteries, and they have a high elastin content, which will dampen or control the surge of blood pressure from the heart. Here are the major arteries of the body. You should be very familiar with the anatomy, both in lab and for lecture. General vascular distribution of the veins is shown here of the veins. Again, be very familiar with it for lab and in lecture. Atherosclerosis and arteriosclerosis is when we have basically your healthy arteries are flexible, strong, and elastic, but over time, too much pressure in your arteries can make the walls thick and stiff. Arteriosclerosis is also known as hardening of your arteries. And atherosclerosis is when you get hardening of the arteries caused by the accumulation of fatty deposits or plaques and other substances. This can affect arteries anywhere in the body, and when it affects arteries to the limbs, it's known as peripheral artery disease. And when it affects arteries to the heart, it's known as coronary artery disease. It can also lead to arteries in your neck or brain, which could cause a stroke. And it could also lead to bulging in the walls of your arteries, known as an aneurysm. The most dangerous fact about either of these conditions is just that they have no symptoms until one or more arteries are so hardened that there's a blockage. And usually it causes a medical emergency by a heart attack or a stroke or a bursting of an aneurysm. Signs and symptoms of these diseases, they develop slowly, but as the narrowing worsens, it will take less exertion to surpass the ability of the artery to supply adequate blood flow. So the most often it will be affecting the arteries in your heart, brain, kidneys, the abdominal aorta, and your legs. Once the inner wall of an artery is damaged, blood cells called platelets will often clump at the injury site to try and repair the artery, but eventually your fatty deposits, the plaques made of cholesterol, will also accumulate and harden, which will narrow the space in your arteries or cause a blockage. So this could make your organs and other tissues not getting adequate blood supply. Your body might respond by increasing blood pressure to maintain adequate flow. This will lead to further damage and inflammation, and it eventually will lead to these plaques to rupture or enter your bloodstream. Risk factors for this are high blood pressure, high cholesterol, high levels of homocysteine levels in your blood, diabetes, chronic kidney disease, obesity, smoking, stress, and a family history of early heart disease. In order to screen and diagnose this, it's really hard to know you have this disease until a serious medical emergency occurs. Regular checkups with your doctor are vital to maintain your health. Blood tests, you can check your cholesterol, homocysteine, and blood sugar levels. You can take an ankle brachial index, which measures the blood pressure in your ankle and your arm to see if there's any difference. You can take an ECG, which will detect any abnormal heart activity. You can have images done of your chest, an ultrasound, a CT or MRI scans. They're just ways to actually look at the arteries for any other abnormalities. Here are complications. A normal artery has normal blood flow. With atherosclerosis, we might get high blood pressure as it begins to kind of restrict blood flow. Eventually, it could completely block blood flow, and that will lead to a stroke in the brain or a heart attack in the heart. And they're the most common causes of death worldwide. Arterio and atherosclerosis is the cause of many other cardiovascular diseases like heart attack, stroke, and aneurysm. So this is where most cardiovascular disease starts, and it's the most important to understand. And before we stop here, I'm just going to take us through one other PowerPoint. And this is the cardiac output PowerPoint. So bear with me as I just pull that up really quickly. And this PowerPoint is important to understand a little more about cardiac output and what's involved with that. And there will be a couple of questions possibly on your exam about cardiac output. So this is only about 12 slides long. So cardiac output is defined as the amount of blood pumped by the heart per minute, and it's measured in milliliters per minute. We calculate it by multiplying your heart rate times your stroke volume. Your heart rate on average is 70 beats per minute, and your stroke volume is the volume of blood in millimeters pumped out of the ventricles with each beat. On average is 70 milliliters per beat. Factors affecting cardiac output. Your heart rate is affected by nervous system innervation, hormones, fitness level, and age. And your stroke volume, the amount of blood that your ventricles eject, will be affected by your heart size, your fitness, your gender, the contractility of the heart, the duration of the contraction, the preload, which is the end diastolic volume, the volume in the ventricles before they contract, and the afterload, which is the resistance. So what is it used for? Cardiac output is important because it can help determine the quantity of blood delivered to different parts of the body. It's easy to only think about the heart when you hear the word cardiac, but there are many factors outside the heart that will affect the cardiac output. We really need to look at what factors can affect heart rate and systolic volume to understand, or stroke volume to understand how cardiac output can change. So cardiac output can change when we look at the heart rate and we look at the neural control by the autonomic nervous system. The sympathetic nervous system raises heart rate, and the parasympathetic nervous system decreases heart rate. You can read here more about the sympathetic and the parasympathetic nervous system, but each one of these will lead to an increase or decrease in the heart rate. There are three major factors that influence stroke volume: the preload, the afterload, and the contractility. And this is a funny caption. What fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day. So an encouragement to exercise and eat healthy. So what is preload? It's the volume of blood entering the ventricles. This is also known as your end diastolic volume, which is the blood in the ventricle right before it contracts. If your end diastolic volume increases, it will cause the heart muscle to contract more forcefully, increasing stroke volume. And in different circumstances, the blood filling the ventricles can increase or decrease, having a direct effect on stroke volume. Starling's law, here's Starling. This law states that the amount of blood entering the ventricles should be the same as the amount ejected by the ventricles. Preload, increases in preload will be exercise, a slower heart rate, which allows your heart to fill more with blood, allowing for a stronger contraction. This will increase venous return by the skeletal muscle pump and respiratory pump. So basically, exercise is really important to increase preload because your skeletal muscle pump and respiratory pump, when you're breathing heavily and moving your muscles, will help with the preload. Decreases in preload are caused by a rapid heart rate, blood loss, atrial arrhythmia, which is any sort of abnormality in your atria contracting, and ventricular non-compliance. Afterload is the resistance of the ventricles must overcome to pump the blood to the body. The more resistance to pump blood out of the heart, the slower the contraction, and this will lead to less blood being pumped. So an increase in peripheral resistance will cause a decrease in stroke volume and vice versa. And an increase in afterload will decrease cardiac output. What increases afterload? High blood pressure, stenosis or atherosclerosis, which is just a narrowing of the blood vessels, thicker blood. And what decreases afterload is low blood pressure. Anything that lowers your blood pressure can help decrease afterload. And many medications given for heart conditions are based on this concept. Contractility is how hard the heart muscle, the myocardium cells, will contract to pump the blood out of the heart. What increases contractility? Calcium, increased sympathetic nervous system or adrenaline. What decreases the contractility? Increased potassium, which causes an imbalance between your potassium and calcium, which will lead to less contractions. Also, increased acidosis. If your blood gets too acidic, maybe there's too much carbon dioxide and too much hydrogen ions. This will lead to an increase in potassium ions and similar reaction as above. So that's a little also introduction to cardiac output, which you should be familiar with the information found there. Thanks for listening, guys.